Today's module is on Thoracic Outlet Syndrome, also called TOS. This is a problem involving pain in the neck area extending into the arm with numbness, tingling, and weakness at times. Patients are often undiagnosed for years because it's not well recognized by primary care providers. This can lead to all kinds of unnecessary testing. And the goal today would be to show some simple bedside maneuvers and history that we can take to get patients an earlier and accurate diagnosis. We'll talk about treatments for TOS once we do the history and physical exam. In terms of history, it's really key to understand that these patients will develop TOS mostly from some sort of trauma. In my practice, it's often patients who've been in motor vehicle crashes. What patients complain of is that when their arm is overhead, they often get numbness, tingling, and heaviness of the arm, including weakness. For example, women patients will complain that they can't wash their hair, for example. And women are much more affected by this disorder than men, probably because women tend to be more generally hypermobile than men. In fact, for whiplash injuries, women generally don't do as well as men, not because they're wimps or anything like that, but probably because of things like generalized hypermobility, more common in the female patient than the male patient. If we look at the anatomy of this disorder, I have a model. What we can see is here's the anterior scalene muscle, the middle scalene muscle, and this bundle of nerves in orange represents the brachial plexus. So this plexus is coming out of the neck, which is shown as blue vertebrae here, into the arm, under the clavicle, and under a portion of the scapula called the coracoid process. Most often with TOS, there's a pinch from the scalene muscles, sometimes from a muscle under here called subclavius, not shown, and sometimes a muscle here called pectoralis minor. Physical examination generally will clinch this diagnosis. And one thing you will see with all of our modules is that we emphasize you should always do a complete exam. Even if you think it is TOS based on history, you need to go through the rigor of also examining the shoulder and do a complete neurologic exam. Now we'll turn to our model patient, Jennifer. Thank you for coming in today. And for any type of upper body abnormality, we do a complete exam. So first I would do is look at neck range of motion, extension, flexion, and at the minimum include axial rotation. Often patients with TOS will have some pain with neck motion, either to the side of the TOS or even to the other side. We're going to assume here today that Jennifer has TOS on her right side. She typically will also have pain or tenderness on exam in the posterior part of the neck. If I turn to the model, that would be in this area by the facet joints. But the key that is specific to TOS, or at least mostly specific, is the tenderness of the scalene muscles and then some of the other muscles involved with TOS. So the patient often will have tenderness just in that area, just lateral to the SCM muscle, fairly focal, much more notable on the side that's more affected if it's both sides. Sometimes they'll have tenderness here just under the clavicle in subclavius, and then often here at pectoralis minor, which is just medial to the coracoid process. It takes a while to learn how to palpate that little area, but with practice you can get to know how to do that and avoid palpating, say, the shoulder joint instead. What we try to do with all of these modules is do a comprehensive exam. Even if we believe it is TOS, we need to go through the rigor of going through other parts of the exam, including the shoulder and the neurologic exam. The simplest shoulder exam, which we will emphasize in other modules, we'd have the patient bring their arm overhead, crossed adduction, and then Hawkins test, which also tests internal rotation. For patients with TOS, might cause some pain up here, but not usually pain out here. That would point us more to shoulder. And the thing to remember, when patients have trauma, they have, as I like to put it, as many diseases as they pleases. Trauma is different than all other forms of medical diagnosis. The patient can have TOS and a shoulder problem. In fact, it's quite common in my clinical practice. So you need to be rigorous and you need to make sure you really detail all the possibilities. I'm going to move now to the neurologic exam. And I cover in another module how to do this in more detail. But basically, we'd have the patient bring their arms out, push out. That will be intact. That's abduction. Bring your arms in. hold it in. That's biceps, hold in as tight as you can. That usually is normal. Push outward. That's triceps or elbow extension. That should be normal. Everything will be normal with TOS until we get to the intrinsic muscles. Wrists up. Wrist extension should be intact. Wrist flexion, intact. Have the patient squeeze your fingers. Finger flexion should be intact. Fingers straight, finger extension intact. And now we get to the subtle part of TOS where there's a difference. And that involves the intrinsic muscles. So here, abductor, that's abduction, pollicis, fancy word for thumb, brevis, because the muscle is a small muscle in the hand, an intrinsic muscle. Put your hand up here, put your finger up there, and that will be intact on this side, but you will more often than not find a subtle weakness on this side. And you have to just test it very carefully. You can't have the hand out like that or the thumb out like that. And then the other weak muscle is another intrinsic muscle, the interossei, which you might remember from your medical training is innervated by the ulnar nerve. And that will also be weak with TOS. So if you simulate here for me, Jennifer, that one will be weak. This one will be intact. Okay? And then there are a couple of specialized tests for TOS that you should keep in mind or at least do to clinch the diagnosis. Classically, people talk about pulse tests with TOS, where they have the patient turn their head and they'll measure the pulse here. I find those tests not very useful. They're not very specific or sensitive. In fact, what we tend to do is something called the upper limb tension test. I have the patient put their arm straight out, and then I say, stop traffic on both sides. And the side that is affected often has a pulling or pain to this side. And often when we stretch further by having the patient's head go to the other side, that will worsen their problem. And then finally with TOS, there's something called the Roos test, R-O-O-S, named after David Roos, a famous vascular surgeon who's worked in this area. And you have the patient bring their arm up 90 degrees, and you open and close your fingers for up to 3 minutes. And typically the side that's affected, in this case the right side, it gets very heavy, painful, numb, tingling. There's often a sensory deficit towards the ulnar part of the hand, in other words, towards the fourth and fifth fingers. Patients generally can't even go more than a minute or so. And that really helps to clinch the diagnosis. A lot of times it's confused with cervical radiculopathy, a pinched nerve in the neck. I've even had patients come in with surgical scars because someone did a misguided fusion on the patient, not recognizing this disorder. Treatment. Early treatment involves postural correction, mobilization, myofascial release, some spinal manipulation techniques. I have patients do chin tucks and overhead exercises like this. And if they can tolerate that, that often helps enough. I used to call this thoracic postural syndrome. If they don't really resolve their injury, we look at more advanced techniques, including something called a scalene motor block, which under ultrasound guidance, we would actually put an anesthetic block with lidocaine into this muscle. That clinches our diagnosis and often actually is a bit of a treatment. If that doesn't give enough benefit, we move towards using Botox or botulinum toxin. And then finally, in advanced cases, we might suggest surgery. I would say surgery, 20 patients, maybe one goes to surgery. Not a great surgery, but a good surgery if someone's not getting better.